I'm Dr. John Oren. I'm the co-chief of Orthopedic Spine Surgery over at Lenox Hill Hospital in Manhattan. And slides prepared. Again, this is just sort of to spur some conversation, give you some background. The fact that many of you are here is awesome. Means that you've taken a big interest in your health to research options for yourself, and hopefully we can help you with that. So a little bit about myself. I trained in New York City. I did fellowships in both neurological surgery and orthopedic spine surgery. Been in Manhattan for the past decade or so in practice. And, we do a wide range of things here between decompressions, infusions, and corrections of scoliosis, and more motion preservation procedures, which TOPS fits into that. I do computerized navigation and robotics for my screw placement. I'm always looking to really utilize enabling technology and newer technologies that come out and how we can integrate and drive care forward. Some of the things over the years that have come out have been these enabling techs to make screws more accurate. Cervical disc replacements became a sort of another thing that we've added over the years and become more and more common, more minimally invasive surgeries, and then more recently TOPS. So most common reasons people come in for back surgery, usually it's for some sort of combination of back and leg pain, the leg pain being the sciatica or the nerve pain that you feel down your legs. Certainly when patients have concerning neurologic issues, whether it's a weakness or numbness in their legs or feet, and certainly if we get to incontinence, that's a problem. And the kind of conditions or diagnoses that we treat range from degenerative disc disease, herniated discs, stenosis, spondylolisthesis, and then arthritis of the facet joints. And TOPS can treat these things. It fits in our armamentarium, and we'll show you where, particularly for spinal stenosis and spondylolisthesis. So what is spinal stenosis? Spinal stenosis just means that there's a narrowing of the spinal canal and the spaces where the nerves come out. We call those the foramen. This puts pressure on your spinal nerves and over time causes a constellation of problems, mostly the sciatica or nerve pain. We call that radiculopathy, as well as something that we call claudication, or this cramping or heaviness or kind of numbness in your legs when you walk that makes you have to stop and sit down. Additionally, it causes back pain, and that's one of the things that we don't talk about as much, but definitely causes a fair amount of back pain as well. Spinal stenosis occurs in the lower three levels, most commonly in our low backs or our lumbar spine. And the reason it becomes a problem is as we stand up, we need to extend our spine. So it's kind of that picture on the upper left there. And by doing that, when we start to get some nerve impingement, we stand up and try and walk, that's closing down the space for our nerves. When we sit and rest, or we bend forward, whether it's with a walker or a cane, we tend to open up the space for our nerves, and that kind of relieves it. But over time, as these things go on, as the quality of life diminishes, that's certainly when people seek us out for treatment. So what is a slip disc or spondylolisthesis? This is basically what this picture looks like right here, where we have these blocks or vertebra that look like they're stacked on top of each other in a smooth arc that can connect all the bones. And then we see this area right here where this bone or this vertebra, this is L4, is slipping in front of L5. And you can see that these lines have been drawn to show the offset or the amount of slippage that's going on. It's happening because over time, usually the level below has become much more stiff. Most commonly, it happens at L4-5, but can happen at these other areas of the spine. And what happens is our spine facet joints become incompetent. They can't hold us anymore. They can't constrain the forces of the back, and it allows these bones to start sliding or toggling back and forth. As it does this, our bones want to hold us and want to create more bone, right? So that's where facet arthritis comes in for a lot of these cases. And you can see these red marks here. These are the facet joint surfaces that are growing extra bone. And as it grows extra bone on the outside, we see that on the scans, but it also grows bone on the inside where the nerves are. And that's what's creating this progressive spinal stenosis. And so for patients who have a slip disc or a spondylolisthesis that is toggling back and forth, year out, year in, year out, these things tend to get worse and it becomes progressive. In terms of treatments, certainly for spinal stenosis and spondylolisthesis and facet arthritis, right, this kind of constellation of symptoms we're talking about, many patients will do fine with conservative care, and conservative care meaning exercise, taking a rest when things are worse, anti-inflammatories, different kinds of injections, stretching, manipulations, acupuncture, right? These are all trying to manage the back symptoms, the back spasm, the nerve symptoms, and can be quite successful for the long run and quite successful for a period of time. The problem is as things get worse, right, as these instabilities continue in the spine and the toggling keeps going back and forth, for many patients, what might have worked 5 years ago progressively stops working. So the stretching routine isn't as effective. The injections used to give you a year of relief and then 6 months of relief and then 2 months of relief, and now they're not working anymore. And these are common sort of stories that we hear when patients come to the office after dealing with this for a number of years. And we'll get scans and see that things have progressed inside and it matches how they feel. Before TOPS came along, right, the two ways that we would treat spondylolisthesis and stenosis were really kind of into two arms. It was either we would decompress the spine, and there would sometimes be spacers are used, although not a favorite of mine. But laminectomies or foraminotomies, these sort of procedures where we're opening up space for the nerves for spines that were relatively stable, although that had some issues, and these spines generally aren't as stable as we think. Or we would jump to a decompression infusion where we put rods and screws in and lock the spine into place while taking the pressure off the nerves. It's a bigger operation. It has mechanical consequences for the rest of the spine. But, for many patients, these are successful options. But it's not perfect, right? On one hand, you have decompressions where, we see patients who get progressive instability or slippages afterwards, or recurrent back pains and nerve pains as the segments continue to wear out. And then on the other hand, we have fusions, which can be quite successful. However, down the line, 5 years later, 10 years later, short or less, depending on the person, we start to see mechanical consequences of the fusion at the other segments. And you hear about, we call adjacent segment disease, or this effect of how the spine is fixed in one area and moving in another area, and it causes the body to respond with progressive stenosis in the other areas. And people come back and say, hey, I thought we fixed this. We did, but now it's in another area. So for some patients, and obviously I don't think this, I think that might be on the next slide. For some patients, this works well. This is what we do, right? And there's different reasons, and we'll talk about this. But that's, we'll talk about TOPS and where that fits into the mix. In terms of lumbar fusion, for many patients, it's the standard of care. We stabilize the spine for these instabilities. We can address a large variety of disorders, but there comes with issues, right? And I'd say the three biggest issues are those bottom three things. One, sometimes the fusion doesn't take, and that's probably around, depending on the surgery, somewhere between 2 to 5% of the time it doesn't take. Screws can loosen and break, and that happens probably in, again, another 5% of patients. So we start to add these up. And then there's loss of motion at the segment, and that starts to transfer stress, and that can lead to more fusion surgery. In some studies we look at that, we quote patients as that's probably a 20 to 25% chance if you have a fusion that you're going to need another one in 10 years somewhere else. So we start to add that up, 5%, 5%, 25%. Now we're about a 1/3 chance or 35–40% chance that you're going to have one of these three issues within a 10-year period. So the question is, can we do it better? And this is where TOPS fits in. So it slides in between, where we get to decompress the spine, we get to stabilize the spine, but we also get to keep it moving, right? And that's that middle area here. And so over the last few years, as we've done more and more of these TOPS cases, it's super gratifying to see patients move and bend in the office in cases where otherwise we would have needed fusion. And see them really satisfied and happy with the results. When we think about what TOPS does, right, and how it works, it allows the spine to be constrained in different directions. So instead of just putting rods and screws and locking that segment into place so it can't move, the spine actually gets to move. I don't know if you can see it here. Here's my model of TOPS. I'll try and show it to the camera. But what you can see is that the spine gets to move about that device. So while it's still supported and the facets are replaced by this device, it's not locked into place. So you can get the flexion extension motion, some rotation, and some side bending. And the side bending is what I was showing you on the camera. Just going to put that down. A little bit about TOPS. So it's been a journey through the years for the company to get this to market, as is with all devices. In 2020, it received a breakthrough device designation. The studies came out in 2022 showing excellent evidence compared to fusion. We were a part of that trial here at Lenox Hill. And then it was FDA approved in 2023 in the fall. And that's when we started using it. So it's been out in the market for the past year and a half or so, and it's the only device that's currently on the market that you can replace these facets, decompress the spine, and stabilize to preserve the motion. And that's what we love about TOPS. So in terms of fusion versus TOPS, right? So we sort of talked about this to some extent, right? Whereas fusion, we're fixing the spine in place. I talk about this all the time with patients. Once we do a fusion, we can't unfuse you, right? So we can't get the spine to move back in that area. We can't undo it. Whereas with TOPS, right, we have a device that is keeping you in place and holding you, but it is reversible. So we can convert it to a fusion if we needed to, if there was some issue. But what we are getting is we're getting this shielding of the adjacent segment stress. That's that area here. So we're allowing the spine to move in that area we're working, which allows for normal mechanics and much more normal mechanics through the whole spine. So we're not generating an overload at these other segments. I do think over time, as I've done more and more of these, patients are getting better quickly. There's something about the spine moving, right? It's the same incision, the same approach, the same decompression, the same putting in screws. The difference when we do TOPS or fusion is the installation of the device versus the rods and screws and the bone graft, but not a whole lot. However, I will say it's been impressive how quickly our TOPS patients get back to activities. There's something about the spine moving that makes people feel better, even early on, when we would expect that they'd be kind of about the same as fusion patients. We've been getting great outcomes in our own patients, and definitely in the trial. There were fewer revisions and less opioid use. So these are also benefits that we saw when we looked at this very rigorously through the scientific process. There are a bunch of institutions that are using it. Northwell Health is one of them, along with a number of these major institutions throughout the country. This is just, I don't want to go through it too much, but this was the results from the TOPS FDA trial. The important things to sort of take home: it was a randomized trial, so super high quality evidence where the patients don't get to pick their procedure, but we're picking the trial. Researchers pick one versus the other. These are patients that are candidates for both. We looked at a lot of different things to be very rigorous about the study. These are all patients with spinal stenosis and spondylolisthesis, that same condition that we're talking about. And what we found is that when we looked at 24 months, the study results in terms of the patients getting better, the composite success score, this is what's published in the literature. When we look at TOPS versus fusion, we look at all the things that go into what was deemed a successful result by the FDA. The patients do better with TOPS. And so that's what has driven me to use it in my own practice. So where I use it, so this is for patients with me, primarily who kind of fit that very active adult age range, who can benefit from a motion-sparing implant. They've got to have enough discs to preserve so the device can actually move, right? If the discs are collapsed one on top of the other, the device isn't going to allow for any motion there. The primary things that we're treating is spinal stenosis, where otherwise we would require a fusion, and a slippage or a spondylolisthesis or slip disc at that area that's in the grade 1 phase. So there's different grades. This is indicated for grade 1. Ideally, these are patients who can have back and leg pain, but are really affected by their stenosis and need a decompression. That means more leg than back symptoms. And I do use it for older adults. If someone's very active, 40 to 70, moderately active, 70, 80, I think they're great candidates as long as the bone quality, and that's where this thing, the DEXA score comes in. If the bone quality can support it, then that's where we definitely want to use it. If the bone quality can't, then it's not the greatest choice, and we can talk about that on the Q&A. So there's just the last slide, and we can keep this up. This is my office number, so it's our direct line. So if anyone wanted to come and see us, they heard, hearing the talk today, and sounds like this fits what you feel like is going on in your body, and you'd like to have a consultation in the office, obviously happy to see anybody. But definitely for the purpose for today, we're going to definitely talk more generally. So if you have something specific, I'm happy to help, but and ask questions and answer questions. Something super particular about you or your case, probably best for the office. So from there, Ron, maybe we'll start the Q&A.
Sure. So I've got a long list of questions that have been streaming in, so I'll try to grab as many as I can, and hopefully we'll get through the majority of them. So one of the patients is asking, a year ago I had a minimally invasive decompression without fusion, and now I'm back to the problems that I had before at L4, L5. Can a TOPS now be used after you've done a previous decompression in the posterior column?
The answer is definitely yes. If you've had a laminectomy or you've had a minimally invasive decompression, either one, it definitely can be used. We do revision decompressions at that area, and we can install the TOPS if it's appropriate. If the minimally invasive decompression was for a big ruptured disc and now you have a recurrent disc herniation, that's probably not the best choice. So these are really for TOPS. We want discs that they can have some bulging and maybe even a little sort of herniation that's contained because of the spondylolisthesis and slippage. That's very common. But if there's a true disc rupture or a big rupture disc, that's not a great choice, because once we do the TOPS, we're going to keep that level moving and keep that disc in place. So if what we're treating is the disc, that's not the right choice. But if we're treating the arthritis and the stenosis, then it can definitely be considered.
Okay. Another patient is asking, if I have more than a grade 1 spondylolisthesis, is that going to rule me out?
If it was kind of right on the border, I think it'd be reasonable to do. Once we get too far along with the instabilities, and it really depends on what the health of the disc looks like to me. The concern, we are now going off trial, right? So we're in the off-label sense of what TOPS was designed for and what it was tested in. It probably could be used in certain kind of select scenarios. But the concern may be that if the ligaments have been moving and sort of stretched out that much, that there may be more stress on the device. So I haven't used it in those scenarios, but in a very select case, maybe. I think in the same question, it said also on patients with less than or worse than negative 2.0 bone density. For me right now, that's a hard cutoff. I mean, maybe if we're at 2.1, I'd consider it, but if we're too far away from that, the concern again is that the device really needs to bond to the bone and needs to stay strong with that connection throughout the lifetime of the device when it's in place. And the sort of less the bone density is, the less grab the screws have, and the more chance to have some loosening of the device or implant down the line. So that's one of those where I really, it makes me nervous to do a TOPS in those scenarios. I haven't crossed that threshold personally. And again, we would be in the off-label side, right, from where we were in the trial. It's probably not the best choice again. Fusions are different because we're adding in a temporary scaffold that only has to sort of be active and holding for 6 to 12 months while the bone graft is healing in and the spine is getting stiffer and stronger as time goes on from the day of surgery on. With TOPS, it has to be as strong on day 30 as it was on day 1, and as strong on day 300 as it was on day 1. So that would make me nervous.
Well, if you see a patient that has stenosis and spondy, what kind of drives you to decide whether you do just like a straight decompression, let's say a MIS laminectomy versus putting in a TOPS? What kind of tips the scales in one direction or the other?
So that's a good question. For me, my algorithm is I'm starting with, is the spine stable or not stable? And there is a little bit of nuance to this, and there are a lot of factors that kind of help me understand whether something is truly stable or not stable. One is how much it moves on flexion extension. The other thing that we use a lot is we compare our standing and our flexion x-rays, which are dynamic with gravity in place, to our laying down MRI position, and we see how much the spine is shifting in that between those two positions. If the spine is shifting a lot and the patient needs a very large decompression, MIS or not, those patients tend to fail down the line. There are certain select scenarios where maybe we're decompressing one nerve, or it's in that case where maybe we'd still consider it, but it's not the best choice for those patients. Those patients need some sort of stabilization. We look also at the way the facet joints look on MRI. Sometimes we see that they're gapped open and there's a lot of fluid inside of them. Again, that sort of tells us, hey, this is not a patient that should just be decompressed, but the nerve symptoms they feel are not just the static pressure on the nerves, but the dynamic compression of how the spine is shifting and moving. Again, those are patients that as time goes on, if we're not fixing the mechanical problem, the stenosis actually will recur and the joints will grow bigger again, and they'll have recurrent stenosis in those areas. So we really try to select these pretty well. We want patients that are pretty well aligned, meaning that they don't need us to correct their alignment through that segment to stand up straight. They're already doing a pretty good job on their own. And so we get standing full x-rays of patients in the office to test their posture. So there's a number of things that go into that. But if we have someone who's got a very stable, maybe a very small spondylolisthesis that doesn't move much, or doesn't move at all between flexion extension, and maybe their joints are very stiff and arthritic already and not this loose back and forth, those are probably the best candidates for just a decompression. And we'll certainly do those for those patients.
What about a facet cyst? What would you do with the patient like that? Let's say L4-5, they have a facet cyst.
So I think if it's a one-sided facet cyst in a again a very small spondylolisthesis that's stable, those are great candidates to just decompress the nerve and take the cyst out. If it's part of this mechanical failure of the facet, meaning the whole segment is toggling back and forth, and it's what we deem unstable, and there's different criteria for that. And maybe it's not just the facet cyst, but they've also got, hey, maybe my left leg hurts the most because that's the side of the cyst, but the right leg's also hurting to some extent. Those are patients that are good candidates for TOPS as long as they have a good disc in place, because we're really treating directly the problem at hand, which is a mechanical failure of the facet that's leading to this cyst. And so by removing the facets as part of the procedure, I think those are really excellent candidates for TOPS. Sometimes, obviously, we try and do the smallest surgery possible and just decompress them, but those are patients, I think, that we didn't really, I don't remember if we talked about as much during the trial, but as the after the device launch, those have been patients who I think are really excellent candidates and have done really well.
So someone's asking here about patients that have multi-level disease. So maybe run us through a situation of multi-level disease, and as you know, there are different manifestations of multi-level disease. So maybe kind of give us kind of an overview of what the different options are.
Yeah, so I mean, TOPS, there are different scenarios here where some patients come to me and not uncommonly have stenosis at maybe 2 or 3 levels at the same time. Maybe it's L2-3, L3-4, L4-5 have stenosis, but maybe only one level has this spondylolisthesis, right? And so really only one level needs to be stabilized. To me, those are really great TOPS candidates, right? Because what we're kind of empowered to do is do the decompression that the patient needs, meaning a laminectomy at each level, and really only to stabilize in this motion-sparing way that one level. Maybe it's that L4-5 level that's slipping. That'd be the most common scenario. And so they get a 3-level decompression, but they get all 3 levels to move afterwards. Traditionally, those are patients that usually would get 3-level decompression infusions. So it's a big difference in terms of mechanically what they get out of the surgery. So that's kind of one of those scenarios where it's 2 or 3 levels of stenosis, but 1 level slippage. The other sort of scenario with multi-level disease that we've been creatively using the TOPS device to help design a more patient-specific solution is, let's say someone has a collapsed or a really, sort of broken down L5-S1 base, which needs a fusion because the nerves are pinched and needs to be realigned. And L4-5 has that slippage, right, and stenosis. So traditionally we do a 2-level fusion with decompression. With now that TOPS is around, what we can do is actually just fuse that one broken down collapse level below and install the TOPS at the L4-5 segment, and allow that level to have motion. Obviously, again, this is outside the trial, and it's an off-label indication. But patients have additional options that they didn't have before, to try and continue with as much motion in their spine as they can in a stable fashion. So I'd say those are the 2 sort of most common multi-level scenarios.
And related to the last example you gave, where you had a patient that presented with 2 levels, 1 level needed to be fused and the adjacent level warranted a TOPS. We have someone writing that she had a previous fusion at 4-5 and now 3-4 has broken down. Can you put a TOPS on top of a previous fusion at the adjacent level?
Yes, so it's a great question. As long as the spine is well aligned, and the disc at that L3-4 segment is healthy, and there's not a disc failure, meaning a big disc rupture at that level, something that needs to be treated in the actual disc itself, TOPS is an option. That to me is what I'd love to see as kind of one of those next studies that comes out, right, to see how those patients perform versus another fusion, because I think, TOPS to me fits in this as, can I prevent patients from going down this cascade of needing sort of multiple fusions, right? And I think that's a great example. And also, can we stop the cascade, right? So we know if we just decompress those levels above a fusion and don't do anything to stabilize it, they don't do that well. but can we install the tops there? And the answer is yes. Do I have the research and the same way that I have from the trial to talk about patients who've never had a fusion? I don't have that study, but we've been doing that for those select patients if it really makes sense, to really try and preserve as much motion and continue with that segmental motion, prevent the spine disease from going up. So it's an option. It has to fit a bunch of criteria. Again, it'd be, for me, it'd have to fit a lot of, sort of check a lot of boxes before I'd say yes. But in those cases, we've been doing that. I think it's an exciting option that's out there now.
Okay, so we've run out of time, but I have one last question as I see it's come up consistently in the chat that involves Medicare. Are you treating patients with Medicare with TOPS?
So the easy answer to that is definitely Medicare and Medicaid approved TOPS, right? And it gets there is no specific authorization procedure with those insurance carriers. The hospital they pay the hospital fees. The same way they pay for other surgical procedures with the same co-payments. They pay the surgeon fees, the anesthesia fees, etc. So we definitely do Medicare patients. We do commercial insurance patients, of course, as well. And as time is going on, the company is working on continuing to make more and more relationships with commercial carriers to make that process more seamless. It's definitely gotten easier over the last 18 months with more success, but definitely like all new technologies, it's a work in progress.
Thanks, John, for your time. Obviously, there's a phone number here if you want to call John's office. If you'd like to write out a more detailed question, then you can send the email to Shelbin. He'll either be able to answer you directly or consult with Dr. Oren and get you an answer. So feel free to reach out on either avenue, and we will have this session recorded and available for those who want to review it. We'll send out a copy to everyone who's on our mailing list. So thanks again, John, and we appreciate your time.
Hey, really appreciate it. It's really nice to see so much interest in the technology, and thanks for having me.